We'll go ahead and introduce our speaker for today. That's Dr. Jessica Nee. Dr. Nee graduated with a Bachelor of Science in Biology from the University of California at Santa Barbara in 2017. She received her PharmD from the University of Illinois Chicago, UIC College of Pharmacy in 2022, and completed her PGY1 residency at NYU Langone Hospital in Brooklyn, New York in 2023. Dr. Nee is completing a PGY2 infectious disease residency at the University of Chicago Medicine and will be working at Loyola as an antimicrobial stewardship pharmacist. Welcome, Dr. Lee.
Thank you for that introduction. I have no conflicts of interest to disclose. So today we'll be reviewing current guideline recommendations on the management of candidiasis, describing antifungal resistance patterns and mechanisms in Candida species, discussing novel therapies for the management of resistant Candida infections, and then developing a treatment strategy for patients with resistant or refractory Candida infections. So Candida has emerged as the fourth most common organism recovered from blood in hospitalized patients. In hospital, all-cause mortality rates in patients with candidemia has approached approximately 25%, and each case of candidemia is estimated to result in an additional 3 to 13 days of hospitalization and 6,000 to 29,000 in additional healthcare costs. Candida are budding yeast and part of our normal human flora in places such as the mouth, throat, GI, and genital tracts. The major routes by which Candida species can gain access to the bloodstream are through the GI tract mucosal barrier via direct inoculation by an intravascular catheter or spread from a localized foci of infection. Based on data from the CDC, up to 95% of all invasive Candida infections in the United States are caused by the 5 species listed here, which includes Candida albicans, which is the most common, Candida glabrata, parapsilosis, tropicalis, and krusei. So some types of Candida have been increasingly resistant to antifungals, and drug-resistant Candida is now considered a serious threat per the CDC Antibiotic Threats Report in 2019. About 7% of all Candida blood samples tested at the CDC are resistant to the antifungal drug fluconazole. And then although Candida albicans is the most common cause of severe Candida infections, resistance is actually the most common in other species, particularly Candida auris, Candida glabrata, and Candida parapsilosis. Since 2015, an emergent species, Candida auris, has been an increasing cause of invasive Candida infections in the U.S., and this species specifically is considered an urgent threat by the CDC, with a number of cases increasing by 318% as of 2018. Looking at its susceptibility to our standard antifungals so far, it exhibits high rates of resistance to fluconazole at 90%. 30% have been seen to be resistant to amphotericin B, and most have been susceptible to echinocandins. So what do our current guidelines recommend on candidemia and invasive candidiasis? These are the most up-to-date guidelines that are available. For empiric treatment of candidemia, echinocandins are recommended to be used as initial treatment. Alternatively, in patients who are not critically ill and are considered unlikely to have a fluconazole-resistant Candida species, fluconazole is recommended. In the setting of intolerance or limited availability to other antifungal agents, or in patients with suspected azole and echinocandin-resistant infections, liposomal amphotericin B is recommended. Definitive treatment is targeted therapy at an organism that is isolated using susceptibility data, and the ultimate goal here in ID is to optimize therapeutic effect with an agent that is as narrow spectrum as possible. For definitive treatment of candidemia, transition from an echinocandin to fluconazole is recommended for patients that are clinically stable, have been found to have an infection caused by Candida isolates that are susceptible to fluconazole, or have negative repeat blood cultures following initiation of antifungals. For infections due to Candida glabrata that are fluconazole susceptible or voriconazole susceptible, higher dose fluconazole is recommended. And then for select cases of Candida krusei that are fluconazole resistant but voriconazole susceptible, voriconazole is recommended. In the setting of resistance to other antifungal agents, liposomal amphotericin is recommended. I just briefly wanted to review our standard antifungals, which includes azoles, echinocandins, and polyenes. The dosing of all of these agents listed is provided here for your reference. The azole class includes fluconazole, voriconazole, posaconazole, and isavuconazole. Monitoring parameters here include therapeutic drug monitoring for all of our azoles except fluconazole. And then we also want to monitor for hepatic and neurologic function, as well as EKG for QTC prolongation. Additionally, drug-drug interactions with azoles should always be evaluated for, since azoles are known to be CYP inhibitors. The echinocandin class includes micafungin, caspofungin, and anidulafungin, and these can also cause abnormal hepatic function tests, which should be monitored for. And then lastly, our polyenes include amphotericin deoxycholate and liposomal amphotericin B. The major adverse effects to monitor for here is nephrotoxicity, electrolyte derangements, and acute infusion-related reactions. So now that we've discussed antifungal treatment options, let's take a closer look at how these antifungals work and their mechanisms of resistance. The structure of the Candida cell wall is shown here on the left. The outer layer is highly enriched with mannins that are covalently associated with proteins to form glycoproteins, and the inner layer contains chitin and beta-1,3-glucan, which confer strength and cell shape. The general mechanism of action by which the azole antifungal family works is by inhibiting linosterol 14-alpha demethylase, which leads to the inability to produce ergosterol, increasing membrane permeability and resulting in cell lysis and death. These are the primary ways that Candida can develop resistance to our azoles. Isolates expressing multi-drug efflux pumps have reduced intracellular accumulation of fluconazole and elevated fluconazole MICs, and mutations in the ERG11 gene, which regulates production of linosterol 14-alpha demethylase and is a target for azoles, leads to reduced azole binding affinity. And then lastly, the formation of biofilms harbor organisms in high density, including those that may have reduced growth rate or upregulated efflux pumps. And it is also just an extracellular matrix material, which acts as a physical barrier to azole drug penetration. Going on to our echinocandins, these work by inhibiting beta-1,3-D-glucan synthase enzyme complex in susceptible fungi to disturb fungal cell glucan synthesis. Beta-glucan destruction prevents resistance against osmotic forces, which leads to cell lysis and death. Mutations of the FKS1 gene of 1,3-beta-D-glucan synthase and upregulated chitin production, which is a structural component of the fungal cell wall, are associated with reduced susceptibility to echinocandins. Mutations of the FKS1 gene also causes cross-resistance among all members of the echinocandin class. And then lastly, naturally occurring polymorphisms of the FKS genes can lead to inherently higher MICs to echinocandins compared to wild-type isolates of other species. Our polyenes, and specifically amphotericin, binds to ergosterol in the cell membrane, ultimately causing concentration-dependent cell killing. It also produces oxidative damage to the cells with the formation of free radicals and subsequently increased membrane permeability. Resistance to amphotericin B is characterized by a reduction in the ergosterol component of the fungal cell membrane, and in a subset of Candida isolates, mutational defects in the ERG genes have been shown to affect the synthesis of ergosterol. And so that brings us to our first assessment question for pharmacists and technicians. Which mechanism of resistance in Candida species leads to cross-resistance among the echinocandin class? A. Mutations of the FKS1 gene of 1,3-beta-D-glucan synthase. B. Upregulated chitin production. C. Biofilm formation. Or D. Drug efflux pumps. Okay, great. So most of you chose A, mutations of the FKS1 gene, which is the correct answer. While all of these choices are resistance mechanisms that we see in Candida, mutations of the FKS1 gene specifically is the one that can potentially lead to resistance to our entire class of echinocandins. Additionally, options C and D, biofilm formation and drug efflux pumps, are specific to our azoles. So now that we've reviewed mechanisms of resistance, let's review how resistance is determined and reported. Antimicrobial susceptibility testing is used to qualitatively categorize microorganisms to help guide clinicians on potential agents to use. When looking at a culture where an organism has been isolated, susceptibility results will show you the MIC, which is the lowest concentration of the antibiotic that inhibits growth of the organism, and most will also have an interpretation based on the qualitative categories on the right. The clinical breakpoint is the highest plasma concentration of the drug that can be safely achieved in a patient to define susceptibility to an organism, and the MIC that you see listed in the susceptibility results will be specific to the organism isolated from your individual patient. And so taking a closer look at the qualitative categories listed here on the right, they include susceptible, and so you would expect that your antifungals at typical doses are likely to be effective. Susceptible dose dependent, meaning there is a possibility of higher drug exposure through dosing, and then resistant, where the MIC is greater than the determined breakpoint and antimicrobials are likely not to be effective. This slide is showing what the CLSI document looks like for antifungal susceptibility of yeast, with the various antifungal agents and Candida species listed, and then the MIC breakpoints and interpretive categories that have been established. For example, if you have susceptibilities back for Candida albicans and you are thinking about using fluconazole, based on the MIC, you would determine if it's susceptible or susceptible dose dependent, and that would help guide your dosing. If you look at Candida glabrata right below, there is no susceptible category. There is only susceptible dose dependent. So you would really be looking at the MIC here to see if it's less than or equal to 32 to determine if you can use high dose fluconazole to treat your patient versus needing to use an alternative agent such as micafungin. There are currently no established Candida auris specific susceptibility breakpoints. Therefore, breakpoints are currently defined based on those that have been established for closely related Candida species and on expert opinion. These are the current tentative MIC breakpoints that the CDC established. And one thing to note is that there is no breakpoint listed for voriconazole and other second-generation triazoles, so current guidance suggests using the fluconazole MIC as a surrogate to help determine susceptibility to our other triazoles. These are the common susceptibility patterns seen in Candida species. Here listed are Candida albicans, Candida dubliniensis, Candida parapsilosis, and Candida tropicalis, which are generally susceptible to fluconazole. Some species I wanted to point out are Candida krusei, which is intrinsically resistant to fluconazole. And then like we discussed, Candida auris, which is often resistant to fluconazole. And so in cases where these species are isolated, you would want to start with micafungin as empiric therapy. Candida glabrata displays reduced dose-dependent susceptibility to fluconazole compared with other Candida species and has a global resistance rate of about 15.7%. And so in some cases, you would also want to initiate micafungin empirically here as well. And so that brings us to our second assessment question for pharmacists. Which antifungal would you recommend starting empirically for the treatment of a Candida auris infection? A, fluconazole 6 mg per kg IV Q24. B, micafungin 100 mg IV Q24. Amphotericin B deoxycholate 0.5 mg per kg IV Q24. D, liposomal amphotericin B 5 mg per kg IV Q24. Or E, voriconazole with a loading dose and maintenance dose. Okay, so most of you chose A, I believe. So going through the answer choices here, the correct answer is actually micafungin. And so we went over the common susceptibilities that have been observed to Candida auris so far, and it's so far demonstrated the lowest rate of resistance to micafungin compared to fluconazole, where we've seen a resistance rate of as high as 90% and amphotericin with a resistance rate of 30%. And we would also infer voriconazole susceptibility from fluconazole. And so because we've seen the lowest resistance rates to micafungin, we would want to initiate that empirically before we have any susceptibility data. And then this is our second assessment question for technicians. Which does the IDSA clinical practice guidelines for the management of candidiasis recommend first line as initial treatment for a Candida bloodstream infection? A, treat with an azole. B, treat with amphotericin B. C, treat with anakinocandin. Or D, monitor clinical status off treatment. Okay, so I think most of the answers, most participants chose an azole or amphotericin B. So just to review, the correct answer is actually C, treating with anakinocandin. So the guidelines recommend azoles as an alternative, and then amphotericin in the setting of resistance or intolerance to other antifungals. And then, of course, a Candida bloodstream infection will always require treatment. And so that's why C is the correct answer. So you might have noticed that there are some clinical scenarios that our current guidelines on candidemia and invasive candidiasis do not address. This includes refractory Candida infections defined as worsening or new attributable clinical signs, symptoms, or radiological findings attributable to Candida while on treatment, pan-resistant Candida infections, or toxicity to current antifungals. So one option that we can look into are antifungals that are in the pipeline. This is a timeline of new antifungals in the pipeline and their FDA approval statuses. Rezafungin and ibrexafungerp are FDA approved for the indications listed, and then fosmanogepix was given FDA Fast Track designation in 2019. Oplaconazole was given FDA Orphan Drug designation, and olorifim was most recently denied approval, with the FDA requesting additional data and analysis for the treatment of invasive fungal infections. This is how they compare with regards to spectrum of activity against Candida specifically. Olorifim does not have any activity against Candida, and the other two agents don't add any expanded activity against resistant Candida compared to our standard antifungals. So we will primarily be focusing on ibrexafungerp and fosmanogepix, which are two first-in-class antifungal drugs with broad-spectrum activity against Candida species. Studies on fosmanogepix have demonstrated its in vitro and in vivo activity against several azole and echinocandin-resistant Candida. However, it is important to note that it is not active against Candida krusei. Ibrexafungerp similarly is highly active against Candida isolates resistant to azoles. However, it has been shown to have variable activity against echinocandin-resistant Candida species. So diving deeper into these new antifungals, ibrexafungerp is a glucan synthase inhibitor that inhibits the biosynthesis of 1,3-beta-D-glucan in the fungal cell wall, and it acts fungicidally on Candida species. To note, ibrexafungerp is structurally distinct from echinocandins and interacts differently with the target enzyme, resulting in a lower rate of resistance to ibrexafungerp compared to our echinocandins and limited cross-resistance between the two classes. These are some of the notable drug characteristics for ibrexafungerp. It is currently only available as an oral tablet, so this would result in a pretty high pill burden when looking at the dosing needed to treat candidemia. It's also been shown to have high tissue penetration to most organs, but may have minimal distribution to our central nervous system tissues. Lastly, there are drug-drug interactions to be aware of, as it is metabolized by CYP3A4. One advantage, however, is that it does not interact with tacrolimus, which may make it a more favorable option in our transplant population than some of our standard of care antifungals. Fosmanogepix is our first-in-class antifungal with a novel mechanism of action that ultimately results in the inhibition of fungal adherence to surfaces, biofilm formation, and germ tube formation, leading to severe growth defects and death. These are some of the notable drug characteristics for fosmanogepix. This drug is available IV or oral. It has a high bioavailability and is extensively distributed to most parts of the body and has a long half-life of about 2.5 days. There have been 2 drug-drug interaction studies that have been completed for fosmanogepix, but results from those are still yet to be published. However, it has not been found to be a substrate for any CYP enzymes, and so we would not expect to see any drug-drug interactions related to that. And so that brings us to our third assessment question for both pharmacists and technicians. Which of the following novel antifungals is FDA approved? A. Rezafungin, B. Fosmanogepix, C. Ibrexafungerp, D. Oplaconazole, or E. Both A and C. Okay, great. All of you guys got this right. So the correct answer is E, both A and C. So rezafungin and ibrexafungerp are both currently FDA approved. Fosmanogepix still has FDA Fast Track designation, and oplaconazole was given FDA Orphan Drug designation. So still pending approvals for both of those two. Now that we've reviewed the spectrum of activity and PK/PD data for these two agents, let's investigate the existing clinical data that exists with ibrexafungerp and fosmanogepix. This is the Fury trial, which is an ongoing phase 3 open-label single-arm clinical study evaluating ibrexafungerp for the treatment of invasive fungal diseases, including candidiasis in patients with evidence of failure to, intolerance to, or toxicity related to a currently approved standard of care antifungal treatment, or are unable to receive approved oral antifungal options. Looking at the interim analysis data that has been released, of the 11 patients with candidemia, 72% have experienced complete response, partial response, or clinical improvement, and one patient has had a stable response. This suggests favorable therapeutic response in patients with challenging fungal diseases and limited treatment options that have been observed with oral ibrexafungerp. These are two studies that have evaluated the safety and efficacy of fosmanogepix for first-line treatment of candidemia. The first one evaluated it in the setting of established candidemia and suspected or documented resistance to at least one standard of care systemic antifungal. And we saw a treatment success of 80% at the end of study therapy here, with an overall survival rate of 85% and a pretty quick time to blood culture clearance. Only one patient experienced a study drug-related adverse event, and the most common side effects observed here were diarrhea and vomiting, and notably no drug-related nephrotoxicity was seen. The second study specifically evaluated fosmanogepix in patients with Candida auris bloodstream infections and similarly saw a high rate of treatment success and survival of 89%, and no study drug-related adverse events were observed. And so based on the existing clinical data, it's difficult to make any clear conclusions yet on how they compare with regards to efficacy for the treatment of refractory or resistant candidemia. If deciding between the two in clinical practice, these are some of the major things I would take into consideration. So ibrexafungerp is available as a PO formulation only, so we would not be able to use this in a patient without oral access or with concern for gut absorption. Both of these agents have extensive penetration to most tissues. However, one difference is that ibrexafungerp has minimal distribution to CNS tissues, while fosmanogepix is able to achieve significant exposure in the CNS. And so that might be a difference to consider if you have concern for meningitis in your patient. We would also expect to see some drug-drug interactions with ibrexafungerp, as it is a CYP substrate and inhibitor, but it has been found to have no drug-drug interaction with tacrolimus, which may be advantageous again for our transplant patients. With fosmanogepix, we don't really expect to see any major drug-drug interactions. And then with regards to spectrum of activity, ibrexafungerp is active against all Candida species, whereas fosmanogepix does not have any activity against Candida krusei. And then lastly, it's also important to consider if we are able to get the drug. So ibrexafungerp is FDA approved, and so we would likely be able to order it, whereas fosmanogepix is not and is still considered an investigational drug available through expanded access or compassionate use. And so we may not actually be able to readily acquire the drug for a patient. Additionally, the expanded access process is pretty time intensive and can take several days to weeks. So for patients where you may need to start therapy urgently, this may not be preferred to ibrexafungerp. And so this is our last assessment question of the day for pharmacists. AB is a 68-year-old male with a past medical history of a kidney transplant presenting with septic shock, found to have an intra-abdominal abscess, status post-drainage. OR cultures have grown Candida auris, resistant to fluconazole, resistant to mycopungin, and susceptible to amphotericin B based on the susceptibility testing that we ran. And the patient is currently on mycopungin, 100 milligrams IV, Q24. What would you recommend? A, evaluate source control. B, switch from mycopungin to liposomal amphotericin B. C, request susceptibilities for ibrexafungerp and fosmanogepix. D, consult infectious diseases. Or E, all of the above. Okay, great. All of you guys got this right. So the answer is E, all of the above. So evaluating source control is always important as it's an important element of treatment, and lack of or delay of source control can lead to worse outcomes for these patients. For every complicated fungemia case, and especially in the setting of a Candida auris infection, we would likely want to get ID involved to help determine if further source control is needed, help interpret MICs and determine a course of action, and help with optimizing duration of therapy. And then to dive deeper into the other two answers, where we would request susceptibilities for ibrexafungerp group and phosphonogapix, and switch from mycofungin to liposomal amphotericin B. It's important to, again, think about the spectrum of activity of our antifungals available and which ones you would feasibly consider for your patients as a current or future option in the setting of resistance or refractory disease, or looking ahead at potential toxicities that might preclude the use of certain antifungals, even when susceptibility is shown. And so for our patient AB, we know that the Candida auris isolate is resistant to fluconazole and mycofungin and is susceptible to amphotericin. So it is reasonable to switch our patient from mycofungin to liposomal amphotericin B, which we know is susceptible. While we do have a viable treatment option for our patient currently, it's also still important to consider if further susceptibility testing should be done. If we're anticipating long-term therapy, a long course of liposomal amphotericin might be difficult to tolerate in a kidney transplant patient, and so it's important to think about other options that are available. As we know, phosphonogapix and ibrexafungerp do have activity against Candida auris, so it would be reasonable in this case to add on susceptibilities for these agents. And finally, to summarize everything we have gone over and incorporate it all into an overall treatment approach for refractory candidemia, pan-resistant candidemia, or in cases where toxicities might limit the use of our standard of care antifungals, we would want, again, to get ID involved to help optimize source control, treatment, and durations of therapy. We would also want to evaluate if full source control has been achieved and try to achieve source control early in the setting of candidemia or invasive candidiasis. We would want to consider the Candida species and the spectrum of activity of the antifungal agents available, and then request susceptibility and testing in cases where alternative agents are needed due to resistance, intolerability, or contraindications to available options, or ease of administration. And so that concludes my presentation on management of resistant and refractory Candida infections.